for the ear, guys. So you mentioned you distribute the topics between you. So who's the two that was in otology
انا
part?
ما ادري صراحه. انا مقسمين انا ومحمد القحطاني ماخذين الهيد اند نيك. اللي ماخذ الاذن يا شباب يتكلم.
دكتور احنا اخذنا الاوتريه اير ديسشارج.
اوكي طيب مو مشكله يا شباب، احنا فقط ما في اي ايفالويشن، ما في شيء، نباكم تتكلموا، بنعرف قديش انتم واصلين في المعلومات وقديش يعني عندكم information in ENT. So there is no any evaluation or any mark. Okay guys, only attending and only we want to hear your sounds. Okay, just think loudly. So Faisal or who was with Autoria?
مساعد ويزيد يا دكتور، مساعد رشود، يزيد الهزالي.
Okay مساعد. So you can read this scenario.
Okay. A 30 years old male, chief complaint otorrhea for 2 weeks associated with facial asymmetry. History.
So
Should I read?
no. So this is enough. You have like this. The patient he come with you is adult male patient complaining of otorrhea mainly for 2 weeks, and now he start to have facial asymmetry in the same side of otorrhea. So what is the questions? He is front of you now. So what is the questions you want to ask?
I would like to ask. I'd like to ask about a trauma. First of all, I would like to ask about the associated symptoms. If there is any associated symptoms.
جايز في عندنا أكثر من 10 ستودنت الآن، 11 هذول معنا الشباب محمد الشهيري.
دكتور ممكن يكون يعني ممكن اسوي جامب، بس انه ممكن تكون مثلا فيشل نيرف بالزي. نسأل عن عن يعني مثلا اختفاء الرينكلز في الفورهيد، او يعني من الاسوشيت سيمتومز حق الفيشل نيرف بالزي.
مو مشكلة الآن. any history we learn from second year of medical. Any history you have a chief complaint otorrhea. So what is the questions for this chief complaint? So first you start the history with the chief complaint. So otorrhea. So onset and duration is for 2 weeks. Okay, it is gradual. Okay, so what else you want to ask after the onset and duration? Progression. Okay, what is
Site.
Progression يا دكتور. If it is continuous or intermittent.
Okay, excellent.
The type of the discharge.
Excellent. So we have to ask about type of discharge and the site. Is it unilateral or bilateral, right? So this is very important. So you have to ask about the color. Is it foul smelling? Is it yellowish? Is it whitish? Is it watery? Okay, so this make the diagnosis more clear for you. So what else, guys? We have this case, right side, otorrhea, yellowish discharge. Okay. So now you want to add other. So you want to ask about other otological symptoms. So this is how we do it briefly in the history, because we don't have time. But you have to focus first in the chief complaint, and then you have to add other otological symptoms. So the patient, he comes with ear disease. So he comes with otorrhea. So what other otological symptoms you have to ask the patient to make it as a negative history? So what else?
Hair loss. Hearing loss, sorry.
Excellent. Okay, so what other than hearing loss? You have to ask about
vertigo يا دكتور.
vertigo.
Tinnitus, fever, pain.
Fever, pain. Excellent. So Other things you think about the complication of the ear. So we talk about the complication of otitis media and
معلش
otitis.
دكتور بس الصوت بعيد، صوتك بعيد.
غريبة أنا رافع الصوت على آخر
الحين كويس.
طيب أوكي. طيب. So we ask about what is the other complication we have to put in our mind if we have otorrhea and facial asymmetry. So one of the complication of the otitis media or the otitis in general is intratemporal and extracranial or intracranial, right? So intratemporal, we have complication now with the facial. Okay, so ask the patient if you have any facial weakness. Okay, or facial asymmetry as this weakness. The other things, if we have intratemporal complication or intracranial complication, what is the most common intracranial complication?
meningitis.
So how we ask the patient about meningitis?
نشوف الكيرنيك ساين وبرزنسكي ساين، نسأل إذا كان عنده فوتوفوبيا وهيديك.
Excellent. So this is an examination. So in history, you ask about photophobia and headache, okay? And
Headache.
pain
وأيضا هاي temperature fever.
and high grade fever. Okay. So what other important point in the history you want to add? So do you think this is enough?
History of trauma, maybe important.
History of trauma, all of these you have to ask about. But the most important things you have to focus on the sheep complaint. After that, you ask about the other related system. For example, ear, you have to ask about other symptoms in the ear. In the nose, you have to ask about other. And then you have to ask about complication and risk factor according to your differential diagnosis in the history. Okay, so in examination, what do you do next?
دكتور أنا آسف بس الصوت بعيد مرة يا دكتور.
طيب كذا شباب.
كذا أفضل.
Breast inspection of the ear.
Okay, so now we want to do examination, okay? So first of all, guys, what is this, left or right? خلينا نشوف محمد الغفالي. محمد الغفالي.
هلا دكتور.
Is right or left ear? So you have it now. Ear
هذه رايت. هذه
Okay, no problem.
Right.
Okay. So I think you don't know how to see right or left. So in general, if you want to see if this is right or left ear, if you have a tympanic membrane perforation like this, it's difficult to see the cone of light, right? So usually we have a constant landmark. For example, this one, you have to see the short process of the malleus, this one, the short process of the malleus. So you have to draw a imaginary line between the 12 and 6 p.m. Okay? So if you find the short process of the malleus in the left side, this means this is the left ear. The other things, you will find the Stachian tube opening. It is usually anterior and inferior, the left, so that's mean this is the left ear. If it was in the right, that's meaning the right ear. So this is what? This is not the Stachian tube, this is the round window. Okay? The other things, if they're intact tympanic membrane, you can't see the cone of light. But usually the cone of light, if it's in the left, so that's mean the left ear. If it's in the right, that's mean the right ear. But sometimes you have a disease in the tympanic membrane, for example, congestion, retraction, perforation, so you couldn't find the cone of light. So the most important to see the constant landmark. So constant landmark, it is the short process of the malleus. So just draw a median line between 12 and 6, and if it's in the left, so that's mean left ear. If it's in the right, that's mean the right ear. So we'll see in the next some exercise in different ears. So what do you think this, guys?
هذه perforated tympanic membrane with cholesteatoma, so it is most likely chronic suppurative otitis media.
Excellent. So chronic suppurative otitis media, Abdurrahman, excellent. So this is a chronic suppurative otitis media. Usually we have two types. So you don't say only chronic suppurative otitis media. So you say chronic suppurative otitis media with or without cholesteatoma. So this is chronic with cholesteatoma. Okay.
تمام معليش تفضل دقيقة. يعني وين بالضبط؟
شوف الماوس عندي ولا ما هو واضح؟
إيه شوف.
So this is a cholesteatoma. Usually it's white, pearly, at the attic aspect of the tympanic membrane, and usually at 12 p.m. at this side. Okay, this is the cholestoma.
دكتور هذه ال unsafe type صحيح؟
Type, yes. طبعا عندك البرفوريشن it can be central and peripheral, it can be safe and unsafe. Sometimes it can be like this. This is central perforation, seems to be central perforation, but there is cholestoma. So you couldn't say, for example, this is safe perforation because it's central, but you have a very big lesion here. You understand? So this is the cholestoma. That you can say it is a tubotympanum or whatever the classification you are follow. But this one, when you describe, so this is what? This is an otoscopic examination. Usually in description you have to say it like this. So this is an otoscopic examination of the left ear. It's showing a tympanic membrane perforation. Okay, big central perforation. There is cholestoma in the middle ear at the attic or at 12 p.m. of the middle ear cavity. It is white and pearl or whitey or pearly mass. Most likely it is cholestoma. Or you say only you describe the lesion. Don't say any diagnosis now. Okay? There is some granuloma in the middle ear. This is a granuloma from the chronic inflammation. So it seems to be like this. This is a normal mucosa of the middle ear. But if you find it like this, this means that there is a chronic inflammation. So this is a
هذه الجرانيولوما دكتور ممكن تتطور الى كوليستوما؟
لا ما تطور الكوليستوما، بس هذه inflammation of the middle ear cavity. الكوليستوما طبعا انت اخذت الكوليستوما. So what is the pathophysiology of cholestoma?
It's the presence of skin in the abnormal place.
Yes. So it is a skin more than mucosa. Okay. So it is the skin outside. It was a tympanic membrane. So how it happens? There is a lot of theory to form the cholestoma. One of it is the retraction tympanic membrane. So first there was a retraction tympanic membrane since long time. There is a pocket here. That's the outer surface of tympanic membrane goes in. Okay. And usually the weakest part of the tympanic membrane is this, the attic, the varus flaccida, the up here. So when we have a stick and tube obstruction, for example, or any middle ear disease, so it will lead to retract this pocket inside. So the outer surface of the tympanic membrane goes in. With the time, it's causing that the growth of the outer surface of the tympanic membrane inside and forming a keratin-like debris, which is the cholestoma. So it goes and then it grows with the time. So it is not a mucosa, it is keratin or squamous epithelium. Okay? The problem that you don't see here, there is a very big here opening, adytus and antrum in the superior aspect. So it goes to the mastoid cavity. So all of this, it goes inside. So if you open here, you will find a very big, this is only the iceberg, okay? So you have very big here cholestoma. So you have to do what? What imaging you have to do?
CT with contrast or MRI?
Excellent. So I will do CT of the temporal bone. Okay. So I will do a CT mastoid to assess the extension of this lesion. Okay, guys.
دكتور هي في الميدل اير صح؟
Yes, middle ear. So we have the middle ear. The middle ear cleft. What is the middle ear cleft, guys? I think انتوا شكلكم نسيتوا ال ENT. الآن لكم كم في ال ENT؟
أخذناه من 4 أسابيع يمكن أو 5.
طيب okay. So what is the middle ear cleft? So when I say middle ear cavity and middle ear cleft, so it's different.
Cavity like maybe.
Okay, so the middle ear cleft, that's mean the Eustachian tube, the mastoid, adytus and antrum, all of them. You will find a very nice picture in Dingra about the mastoid or the middle ear cleft. So when I say middle ear cleft, you have to know all of these area. So you know what I'm talking about if you understand that picture. Okay, so now we know this picture. So this is a chronic supracutis medial cholestoma. So what is next, guys? So this patient, he come with facial weakness. So it's explained now why it's happening, right? So what why do you think this patient has facial weakness?
Yes.
ممكن because of intracerebral complications
No, it's important.
او بسبة الفيشيال نيرف، مرور الفيشيال نيرف
Excellent, عبد الرحمن.
جو الميدل اير.
بعدين نايمين والله. Excellent. So we have the facial nerve is passing through the middle ear cavity, right?
Yes.
I don't want to go in more detail, so it will take a long time. So we don't take a long time, only 1 hour. So the facial nerve goes, it has intertemporal, it has a middle ear cavity part, it has extra temporal part, and in the middle ear is usually passing between the oval window and round window. We don't want to go in these details. It's morely with resident level, but we have to know that the facial nerve is passing in the middle ear. So any middle ear disease, it can cause facial nerve paralysis. Whatever the facial nerve is exposed or not exposed. Sometimes it's exposed, congenital exposed, the facial nerve. There is no any bone over the facial nerve. Sometimes no, there is erosion because of the mass in the middle ear cavity. For example, like this, cholesteatoma, it erode the bone and it's causing a facial nerve paralysis because it's pushing the facial nerve or it is compressing the facial nerve. So once you remove the cholesteatoma, most likely that the facial nerve, it goes and it become more normal with the time. Okay. So both diagnosis, we say investigation, we say CT. So what's the treatment? Cholesteatoma. أنا نختار واحد بدر.
اهلا دكتور.
أنا بدر ما سمعت صوتك. أعطينا التريتمنت الكوليستاتوما.
Removal, دكتور.
Removal. So what's the name of removal? What any operation you know it in the ear?
بالضبط ما أعرف الاسم دكتور.
Okay. So anybody knows it, guys? Cholesteatoma.
دكتور ماستويدكتومي.
Excellent. So mastoidectomy. So the mastoidectomy is cleaning of the mastoid hair cell. Why mastoidectomy? Because we have to open behind the auricle, behind the ear. We do incision 3 to 4 centimeter. We elevate, we find the periosteum. We drill, we have a special landmark. And then we go to mastoid hair cell. We have to clean all the mastoid hair cell because this cholesteatoma, it goes to the mastoid hair cell more than the middle ear. The middle ear is only you see this, but we have a very big mass, it going up to the mastoid hair cell. So we have to clean all of these by mastoidectomy. The mastoidectomy, later on, if you are interested, you have to find there is different types. It depends on the location, depends on the size of the cholesteatoma. Okay, so we have radical, modified radical, whatever. So we don't go in this detail. So this is the first case. So, okay. So what is this, guys? خلينا نسأل مثلا سلمان. سلمان, what is this graph?
نسيت الاسم.
Okay, anybody?
تمبانومتري.
Okay, tympanometry. إذا شفت الماشين, this is tympanometry. But this is tympanogram. Okay. So هذا tympanogram, guys. So we have different type tympanogram. So which type is a normal type?
Type A.
Type A.
Excellent. So type B, what is the differential diagram?
If there is a fusion, it's immediate fusion.
Perforation.
Excellent. So what do you think in the last patient, if you did tympanogram, which type of tympanogram
Type B.
you will? Tympanogram. Okay, so you have type B tympanogram. Okay. Excellent. So we have perforation or fluid, middle ear fluid. So we have type B. So what about type C?
Stake tube dysfunction.
Excellent.
Tympanic membrane retraction.
Retraction or stacking tube dysfunction. So we have stacking tube dysfunction. It causes retraction of tympanic membrane. So both of them, it's clear. Sometimes we have other things. I don't want to make it confused, but this is the main things that you have to know. What about the AS and the AD? Anybody knows? Any idea? Okay. So this is meaning the AS is meaning more stiffness in the tympanic membrane, usually in otosclerosis, and AD it's more flexible tympanic membrane, and usually in the ossicular discontinuity after trauma. So the tympanic membrane become more flaccid. So it gives you a very compliance, very high compliance. In contrast to the AS, you more resistant because otosclerosis, so the tympanic membrane is not moving because there is something holding the ossicles and tympanic membrane. Okay, clear guys about the first three types?
Clear.
Okay, so in the last patient, we have type B. Okay, did you know about the external hereditary canal volume? How to differentiate is it tympanic membrane perforation or effusion? I think anybody knows? Okay, okay, I think this one we will not go in details. So this is how we see, for example, the last patient, if he trying to close the eye, there is asymmetry. Okay, so what do you think, Fahad? Which side is paralyzed or weak? Fahad Al-Amir?
Yes, Doctor. The left one.
The left one. Okay, it's wrong. Okay, guys, so it's right.
Right.
Right. So first of all, we don't know about the wrinkles because we didn't ask the dynamic actual examination. But here, in the non-dynamic examination, we will find there is not complete closing of the eye, right? So the right eye is not completely closed. The other things, actually, this picture is not in the same patient that we presented, but I just bring it from the internet, and usually this is the sign of the Bell's palsy. So you find that the eye is moving upward and laterally. So this is the typical phenomena of the Bell's palsy. Okay.
دكتور في سؤال بسيط بس. البلز فينومينا حقت الاي هي نورمال ولا باثولوجيك؟
This is normal, but in the Bell's palsy, it's become more obvious because you close the eye, and the eye is not closing very well. Okay, so you see this is the turning up and lateral, but it's abnormal. It's not normal, completely normal. Okay.
واضح.
So what are the other signs in the facial pulse here? What do you think in the
nose nasal fluid.
So absence of the nasolabial fold. Do you see my mouse? So this is a nasolabial fold, right? يا شباب.
ايه صحيح.
Here absent of nasolabial fold is other sign. The other sign, the corner of the mouth is dropping of the corner of the mouth. So this is the other sign of the facial weakness or facial paralysis. Okay, case 2. Anybody knows?
Retraction.
Okay, so describe what you see. What is this? If I told you.
I see inflammatory tympanic membrane.
Okay.
Loss of cone light reflex.
Okay. Bulging, congested, erythematous, loss of light.
Say that there is a fusion between tympanic membrane.
Yeah, it can be examination, but now we couldn't see dynamic examination, but this it doesn't reflect any fusion. Excellent. So what is the spot diagnosis for this?
Acute otitis media.
Okay, so this is acute otitis media. So this patient, the acute otitis media, he come after 3 days. You give the treatment, everything, and now he come after 3 days with high-grade fever and swelling behind the ear. So what do you think? What is this?
Mastocytitis.
Excellent. So this is the intratemporal complication, Abdurrahman, and excellent it is mastoiditis. Other one who answered about mastoiditis, good. So this is the mastoiditis. It's one of complication of acutitis median, intratemporal complication. So this is the mastoiditis. So what is the treatment of mastoiditis, guys? Yesterday, I think, or the last week.
ممكن نسوي نفس الحكايه ماستيدكتومي موديفايد ولا
ما بين modified ما بين لما يجيك زي كذا. This is only like incision drain, so we call it cortical mastoidectomy. Okay, we just want to open and we relieve the drainage, whatever it's pus or. Okay. So there is different. When I say cortical mastoidectomy in here, it's like incision and drainage. It's called incision and drainage. Okay, guys. So I will do cortical mastoidectomy. I can do myringotomy. I gave antibiotic, and for sure I will do culture for any secretion or the sensitivity of the antibiotic. Okay. What do you think, this guy? Okay, so this is tympanic membrane perforation. Is it safe or unsafe type?
هذه السيف type tube tympanic.
Tube tympanic, excellent. So this is a safe tympanic membrane perforation. I will not go in the case scenario here. So what's the treatment of tympanic membrane perforation safe type?
يا اما نسوي observation ولا tympanoplasty.
Excellent. So usually we do observation if it's very small, less than half centimeter. But if there is a recurrent middle ear infection, so we have to ask the patient or tell the patient it's better to do tympanoplasty. Okay, so tympanoplasty, that means we close this perforation. So we do usually refreshing of the edges, all of these edges. We refresh it. Okay, we cut it by special instruments, and then we put a graft, whatever it is, autologous or it is from outside, like other well-prepared graft. It's a synthetic graft. You find it outside. We just put it, but we have a different way and different technique of the overlay, underlay. So don't go on this details. So this is Muhammad Al-Ghafali or Rakan. So this patient, he went to the swimming pool before 3 days, and now he presents to your clinic complaining of the otalgia or ear pain, mainly in the left ear. It's bilateral, but mainly in the left ear. And sometimes he has discharge, ear discharge, foul smelling. So you examine the ear. This is an otoscopic examination of the external canal, and you find this. So what do you think? What is the diagnosis?
I think it's fungal.
Candida.
Okay.
Could say otitis externa.
Excellent. So this is otitis externa. I know about the candida, but this is hair, guys. Okay, this is not any fungal or something. This is the hair in old man, but it's okay. So this is otitis externa, bacterial type. I will show you the fungal how it goes. Okay. So this is the otoscopic examination. It shows the fungal debris. It is blackish spots on the different aspects of tympanic membrane. The patient usually complaining of what in fungal, guys? We usually give you a keys about the fungal in the ear. Usually there is, anybody knows?
يكون عنده foul smell.
Okay, foul smelling, ear pain, all of these. So what else? Itching, okay? So we have a very, this is a very important landmark in fungal. The patient is feeling of itching and with the pain. Deep-seated itching and deep-seated pain. Okay. So what is this black spots? What do you think, guys?
هذه الهايفي ممكن تكون.
Excellent, Abdurrahman. So this is the hyphae of the fungal. So we have a different organism that's causing fungal infection. So what is the diagnosis? What is the diagnosis now?
Otomycosis.
Excellent. Abdurrahman, أنت عندك البرزنتيشن؟
لا.
شكلك أخذه قبل الشباب اللي قبل. طيب اكسلنت عبد الرحمن، ما شاء الله عليك. طيب كل الشباب الصراحة ممتازين، لكن عبد الرحمن شكله يعني more oriented about the today tutorial.
سوري بي سي دي.
طيب okay Rakan. So these automycosis, there is different fungal causing or bugs causing this. So what do you think? What is the main or what is the most common fungal causing automycosis?
كانديدا واسبرجلس.
Aspergillus, excellent. So aspergillosis, so we have Aspergillus niger like this. We have Aspergillus flavium and Aspergillus niger. So Aspergillosis or Aspergillus species, we have different species. Like this, if you have black dots, it's usually 90% is Aspergillus niger from its name, niger, that's from the black. Okay. خلينا نشوف فيصل رحيم.
تفضل.
Okay, so this patient, he's a boxer. After 4 days, he comes to you in the emergency room. He complaining of auricle pain. And you examine the patient, you find it like this, the left ear. So what do you think?
diagnosis مع cotton flower ear أو شيء زي كذا.
Okay, cauliflower, it is a complication of this. So what is this? Before it happening, the cauliflower. So now he is a boxer, come only after 3 days. So what do you think? What's happening inside?
Inflammation, I think.
Okay, inflammation or anybody knows?
edema.
auricular hematoma.
It can be auricular hematoma. It can be inflammation, but here it's not inflammation, it's hematoma more than inflammation. So hematoma, and after that, what is the treatment?
Drainage.
Okay, drainage or evacuation of hematoma. Usually in hematoma we say evacuation of hematoma. Okay. So what is this? أخذتوها يا شباب هذه ولا ما أخذتوها؟
ما اعتقد اخذناها.
Okay. Okay. So what is this spot diagnosis? If I told you this is the case that the patient he come with ear pain and left facial weakness. Examination, you found this.
رمزي هند syndrome.
Excellent. So this is Ramsey Hind syndrome. What's the treatment of Ramsey Hind syndrome?
Isclovir.
Okay. Antiviral. You give cortisone or not?
Yes, cortisone.
Okay. You give a cortisone, antiviral, and you give also painkillers. Okay. What is the organism that's causing herpes or the Ramsey Hunt? Is it herpes simplex or herpes zoster?
herpes zoster oticus.
Excellent. So this is usually how the presentation of this case. So usually we have a facial symmetry with blisters on the concha of the ear. Okay. There is one, I don't know, there is no name on the participant. His ID is M.5.43. What is this? Who is this, guys?
ساعد يا دكتور. ساعد.
أنا مساعد. What is this مساعد? What do you think? What is this?
Ventilation tube.
Excellent. So this is a ventilation tube. We have different type. We have T-type, and we have like round. It's called shivered and shaft. But just say this is a ventilation tube or grommet. Okay. So why we use this?
Fusion of the
Okay, is it? So mainly we use it for otitis media fusion, which is not treated or not resolved after 3 months. We can do grommet. So what other indication to use the grommet? Anybody knows? No?
ممكن retracted tympanic membrane.
Excellent, Muhammad. So we have otitis media fusion, we have retracted tympanic membrane. We usually put in retracted tympanic membrane. Why? because there is a problem in staking tube.
Negative pressure to equalize it.
Yes, excellent. So to equalize the negative pressure that's happening from the staking tube of retracting panic membrane, so to prevent what? So why I put this in the retracting membrane? So to prevent which disease? We just discussed it in the first case.
To prevent chronic media.
Okay, to prevent other things. We have retraction. So retraction. What will happen?
Station tube.
Yes, the problem is in staking tube. Okay, so staking tube dysfunction causes retraction tympanic membrane. So why I have to put tube? Why I have to put tube in retraction tympanic membrane? So if I leave this patient without tube, after 6 months, the retraction will increase, right?
مع السبون will get fractured.
Okay, but you will become, first of all, you have a complication. If you don't put tube in retracting membrane or staking tube dysfunction, you will have adhesive otitis media. So there is no space between tympanic membrane and the middle ear ossicles and the middle ear cavity. So you have only tympanic membrane immediately adhesive to the promontory. Okay, the lateral wall of the middle ear cavity is called promontory. So you don't have a space. Space is very important, right? So this is the first thing. What will happen after that? So the patient, he feel of pain, he feel of the conductive hearing loss, he feel of blockage. What other most important complication? We just discussed the cholesteatoma, guys. Okay, so you have negative pressure, retraction. It will cause here cholesteatoma. So we want to prevent all of these complications by grommet. Okay, who has a rhinology or nose?
Yes, me and
Rakan? Okay, where is Muhammad? Badr or Muhammad?
هنا يا دكتور.
Okay, Rakan, so read the scenario.
22 years old Saudi male patient presented to you outpatient department complaining of facial pain and renal.
Okay. So what you will want to ask in this case?
I will start asking about the rhinorrhea. When did it start?
Okay.
And what was the discharge?
Okay.
And,
So it is yellowish discharge.
and I will ask about there is a history of upper respiratory infection.
Excellent.
Ask about ear symptoms.
So first we'll go with the same system. So he come with the nose, with something in the rhinology. So you have to ask about other rhinological symptoms. So rhinorrhea, what else? We have to ask.
Anosmia.
Excellent. So he has anosmia as well.
Sinusitis.
Sinusitis is not symptoms, okay, it's diagnosis.
بس إذا في أي headache.
Excellent.
Loss of appetite.
Loss of appetite.
Smoking.
Okay, all of these risk factors you have to ask. Okay. Postnasal drip, epistaxis. Okay, so you have to ask about these symptoms of rhinology. Okay. So you did the examination for this patient. This is scope for this patient, and you go through the scope and you find this in the middle meatus. Okay. So this is a yellowish secretion from the middle meatus. That's meaning what, guys? So middle meatus is drained what? Which sinuses?
Anterior group sinuses.
Yes. So frontal or maxillary or anterior one. Okay. So you find this yellowish discharge. You go inside and you find that the postnasal drip also, there is a postnasal drip that the secretion is going up to the nasopharynx, and then the patient is feeling of the drip in the throat, back of the throat. So he swallowed this. So this is why we ask about the postnasal drip. Okay. So what is the diagnosis of this guy? The patient, he come with you with upper respiratory preceding by upper respiratory tract infection. He has now nasal discharge, yellowish, headache, low-grade fever, and examination-wise by the scope, rigid sinuscope, you find there is a yellowish secretion. So what is the diagnosis?
Rhinosinusitis.
Okay, so
Viral infection.
okay, so this is the acute bacterial rhinosinusitis. I think I bring one questions about the acute bacterial rhinosinusitis definition of something in the exam. I didn't remember. Okay, so should we do CT in this patient? No need to do CT. So we have whatever we did scope, so it's enough. So what's the treatment of the acute bacterial rhinosinusitis?
We give sprays. We give Local and
Okay.
we give atropine as a doctor.
Okay, atropine, you give steroid, you give a painkiller, and antipyretic, and you give antibiotic. So which antibiotic you give?
Amoxicillin.
Excellent. So this is other case, the CT scan. So what do you think? Anybody knows what's happening here?
Left maxillary sinus. It's congested.
Okay, so this is the left ossification of the left maxillary sinus and left ethmoid sinus. So this is usually, when I say it, how we can say it. This is usually the air that's black. So that's mean this is normal side. Okay, but if you find something like this ossification during the CT, so this CT coronal cut at the level of the maxillary sinus, it showed ossification, full ossification of the left maxillary sinus and anterior ethmoid. This is how we do this. Usually this is the sometimes it comes in acute inflammation or if there is a bullet. Okay, but you have to have scope with this. Okay, who was with in the clinic?
دكتور عندي سؤال بس.
اتفضل زيد.
الاكيوت بكتيريال هي هاي جريد ولا لو جريد فيفر؟
الاكيوت بكتيريا بتعطينا low grade fever لكن it's not mandatory. Sometimes the patient he come with high grade fever 39. It depends on the definition. So definition we have a high grade fever, but usually the patient come to the clinic with the low grade fever. Okay, according to definition it's high grade.
Okay.
So what is this instrument, guys?
Speculum.
Nasal speculum.
Yes, nasal speculum, but we have to know we have different types of nasal speculum. So what is the
Bayonets for slips like this.
No, bayonet force is different, totally different. So the nasal speculum, we have two different types. We have Thadicum nasal speculum, and we have Killian. So what do you think? This is Killian nasal speculum or Thadicum nasal speculum? Okay, so I think this in OBD session, the group that was with me, I told them about the name of all instruments that we needed. So this is called Killian nasal speculum. So it's used for what?
Opening the nasal tears.
Yeah, it has a name, guys. Like for example, if I show you studies, for example, I show you how I can understand. For example, I show you otoscope. So otoscope is used for otoscope examination. But this one is a Killian nasal speculum. So it's used for what?
Interior nasal examination.
Anterior nasal examination, or it's called Abdurrahman. You know, what is the anterior nasal examination? Anterior rhinoscopy.
Space anterior space ما ادري زي كذا.
Yes, so it's anterior rhinoscopy. So to be more precise, it's anterior rhinoscopy. So we have anterior rhinoscopy and we have posterior rhinoscopy. Usually the posterior rhinoscopy we do it with the scope, and anterior rhinoscopy we do it with the nasal speculum, like Killian nasal speculum. So this is how we can do it in the clinic, and you can see the anterior aspect of the nasal cavity, You can't see the inferior tegument hypertrophy or nasal polyps. You can't see only the anterior part. So this is how we go, and you see in the middle meatus there is a polyps. Okay, so this is how we go with the scope. I don't know if you see some polyps in the clinic, guys.
ما اتوقع شفنا.
Okay. This is the chronic. Okay, so what is this, guys?
Septal deviation.
Okay, so this is septal deviation. So what is the diagnosis for it?
Right nasal deviation.
Yes, deviation. But what is the
مثل obstruction.
no? What anybody knows? Abdurrahman, you know? Okay, so this deviation is a symptom. Okay. So what is the treatment of this?
إذا كانت asymptomatic نسوي observational بس، لكن إذا كانت symptomatic نسوي
Septoplasty.
Excellent. So this is a treatment of septoplasty if it's symptomatic. If asymptomatic, we do observation. Excellent. Okay, so what is the complication of septoplasty, guys? Give me any complication of septoplasty.
nasal hematoma.
Excellent. Hematoma. What else?
Hemorrhage or bleeding.
Epistaxis. ما نقول hemorrhage.
Or epistaxis, yes.
Hematoma and epistaxis. What else?
Recurrence.
Recurrence.
Infection.
Infection. Rhinitis.
Brain abscess.
What do you think this? Is it a complication? No complication or no?
The perforation.
Excellent. So this is septal perforation. So septal perforation, we have different varieties of causes. One of it is iatrogenic after the septoplasty, but there is other causes of septal perforation. Okay, so whatever is infectious, or we have like trauma, post-traumatic. Okay, so all of these, it is the complication of or formation of septal perforation. Just a minute, guys, because I have my kids, they came. Okay, guys. So this is the case of epistaxis part. I think I bring this in the exam, right? Okay, so the last exam. So I think you are familiar with this slide. So what is this area, guys?
Little area.
Little's area or Kesselbach area.
Kesselbach area. So you have to know the blood supply of the Kesselbach, the internal external carotid that's branches that's forming the Kesselbach. So I want to tell you what is the Woodruff plexus.
The septum the posterior nasal septum beneath the inferior turbinate.
So what is the branches that is forming the Kesselbach plexus or the Woodruff plexus?
Posterior ethmoidal and sphenopalatine.
Excellent.
Branch of it.
Excellent. So this is very important, and usually it comes in adults or in pediatric or in all.
In adult.
Adult.
More than 40 years old.
Excellent. So this is very important to differentiate between the anterior bleeding and the posterior bleeding, and usually the anterior is coming in the pediatric population, while the posterior come in the comorbid patient or adult and old patient.
Doctor, the problem in pediatric will be in the anterior arteries from the
Yes.
same.
This is plexus. So what is the causes of the pediatric epistaxis? Why it happening?
Finger
dryness
bitting usually.
or finger pitting.
Excellent. Okay, so we'll go with the pharynx part. So we have this examination of the pharynx and the throat and the oral cavity. So what do you think, this guy? The patient come with a high-grade fever and odynophagia. So you examine the patient, you find large tonsil like this. So describe, guys, what you see.
Erythematous tonsil with exudate.
Okay. Good. Excellent. Bilaterally, there is exudate.
Bacterial, likely.
Yeah, it most likely it can be bacterial from this signs. Okay. So what is the diagnosis here?
إما bacterial adenoiditis or infectious mononucleosis.
Yeah, it can be. We have differential diagnosis of pseudomembranous tonsillitis, but here we are talking about follicular tonsillitis. These are follicles. This is a follicle of tonsil. It's filling with a pus. It's called acute follicular tonsillitis. This is a very typical presentation of acute bacterial or acute follicular tonsillitis. So what is the most common organism? Okay, what else?
الأورجانيزمز الثلاثة المعروفة.
H. influenzae
Okay.
and Moraxilla catarrhis.
Excellent. So this patient, you give antibiotic, okay, and antipyretic, and you discharge the patient home. After 5 days, the patient will come with muffled voice, hot potato voice, and he have very severe odynophagia. You examine the patient and you find the throat become like this. So what do you think? What's happening? What's the complication of that disease to form this complication? You have this, and after 5 days, the patient come to the ER with trismus, drooling of saliva.
Adenoiditis.
So muffled adenoiditis. Adenoid is not appearing here. Adenoid here, behind the soft palate. Now we are in the oral cavity. Okay, so this is a tonsil, and here the posterior pharyngeal wall. The adenoid is here, behind this, behind the soft palate. You have to see it from the nose. Okay.
Obstruction.
هنا كوينزي كوين دكتور.
Excellent, Abdurrahman. So this is the Quinsy or the peritonsillar abscess. Okay. So we have the peritonsillar space. Okay. You will take one of the seminars. It's called Dybnik spaces. One of the space you will discuss is the peritonsillar space. It is a space between the lateral capsule of the tonsil and the superior constrictor muscle. There is a space, and usually if there is any pus after the bacterial infection, it will accumulate at that area. So when accumulate, it's pushing the tonsil medially more and pushing the uvula to the other side. So this is what's happening here. So the patient now he has special symptoms for this. It's called Quinsy or peritonsillar abscess. The patient he has trismus, he has drooling of saliva, he has a hot potato voice, and he has high-grade fever. So what is the treatment of the Quinsy?
Mainly drainage.
Okay, so it is incision and drainage and antibiotic. After culture, and you give a broad spectrum antibiotic. After the culture, you give according to the culture sensitivity. So usually we open, this is the base of the uvula, and this is the anterior tonsillar, the anterior aspect of the anterior tonsillar pillar. So we open between the base of the uvula and the anterior tonsillar pillar. So only we open here, and all the pus is coming out. And usually we do it in ER, okay? Unless the patient is pediatric, so we do it in operating room. So we just put xylocaine spray, okay? And then after 2 minutes, you just open here by the plate 11, and you drain all the pus. Okay. This is an 18-month-old boy come with Strider. You did the flexible fiber optic examination of the larynx and you find this. So what do you think, guys?
Laryngomalacia.
Okay, laryngomalacia. So what is the type of Strider in laryngomalacia?
Spiral.
Glottic.
This is the epiglottis, okay? So the epiglottis is folded, and during inspiration it goes in to the laryngeal inlet. So these are very important signs for the laryngomalacia. When the patient is crying, it is opening, while the patient also, if he is in the prone position and supine position. Which position make this laryngomalacia more better?
typod position. صح.
ها شباب.
Sitting position or standing position.
No?
Forward.
Okay. So nobody knows about laryngomalacia?
The kid is sleeping.
Prone position.
Excellent. So we become in the prone position, the patient become more stable than supine position. Okay, so what is the treatment for the laryngomalacia?
After 1 year, it's become better.
هي غالبا ريزولف زي دكتور، لكن اذا كان الطفل كبير ممكن يا اما تكون ميديكال، نسوي ميديكال انفولفمنت ولا سيرجيكال انفولفمنت.
Okay, excellent. So usually we do observational, okay, because usually this laryngomalacia come in premature patient. So premature infant, usually the laryngeal structure is not really not well developed. So we give him a time, but still we have sometimes it's grading. So if the patient becomes cyanotic, so we couldn't make observation. But if the patient is stable, only it is Strider, so this is make them as observation. But anyways, you just remember that if you have laryngomalacia in this course, you have to do observation. The other option, it is a surgical intervention. So there is a lot of surgical technique we do here, whatever epiglottidiexy or epiglottic resection. So just remember, we do the option, we have observation or surgical intervention. If the patient airway is not stable, we do surgical intervention. If the patient airway is stable, we do observation. Okay.
دكتور عندي سؤال، في حالة الريفلكس يجي مع اللارينجوماليشيا نسوي سيرجري صح؟
ما نسوي surgery, but it's increasing the symptoms. Okay, so it's increasing the symptoms. هو ما يحدد الريفلكس انه نسوي سيرجري ولا، اللي يحدد اللي هو الاوكسجين ساتوريشن، الساينوزيس، الاوبستراكشن سليب ابنيا، الديريز. So this is اللي يحدد لك اللي هو الايروي اوبستراكشن. تمام؟ يزيد.
سم.
You got it or not?
Yes, I know. Yeah.
Oh, what is this?
Vocal nodule.
So why you vocal nodule?
Because it's bilateral.
Excellent. Bilateral. Anterior 1/3 and the posterior 2/3, the junction of the anterior 1/3 and posterior 2/3 is the maximum bulk of the traction. Okay. So usually it come in what? In the singer nodule. This is why we call it singer nodule, because usually come in the singer or the screamer. For example, teachers or the one who using the voice improperly. For example, he scream a lot, he go to cheer football team, whatever. So he use the sound falsely. So what's the treatment of vocal cord nodule?
Voice therapy.
Voice therapy. Anti-reflex.
Yes, anti-reflex is very important. So voice therapy, anti-reflex, stop smoking. So all of these is very important. So what is this?
Polyp.
Why you said polyp?
Because it's pedunculated.
And because it's unilateral.
Unilateral, excellent. Because sometimes, guys, believe me, I have a lot of patients, a lot of students that come in exam, they say this is nodule. So just focus. So nodule is different, totally different. The single nodule, this is a polyp, not nodule. Whatever is pendulated or not pendulated, this is a polyp because it's unilateral. Okay? So what is this? The patient come with hoarseness for 3 months. It come to you. You did the flexible fiber optic larynx. You find a vocal cord whitish pack is not moving away. When you try to move this white pack, it's not moving away. So what is this? What is it?
لوكوبليكيا.
مين قال كانديدا؟ محمد فهد؟
لا دكتور.
Why candida?
Because it's like the oral thrush. It's similar to the
سكويموس سيل كارسينوما.
No,
هذه لوكوبليكيا يا دكتور.
Is it LPR دكتور؟
not LPR. LPR يعني laryngopharyngeal pathology, okay? But it's other things. So differential diagnosis you have. It can be infectious, okay? You said
Malignant.
it is, for example, fungal, oral thrush, candidiasis, but it's not. Why? Because it's only here in one side, one subunit. So it's always, if you have a candida, for example, you will find the patches everywhere, right? It's not only like this, in one side, in one subunit, for example, vocal cord, oral vocal cord in this. So what do you think? If
هذه
you have only
لوكوبليكيا يا دكتور.
leukoplakia, excellent. So this is a leukoplakia because it's only in one subunit. It is not patchy, it's not everywhere. It's only in one subunit in the right vocal cord. What about this one?
Squamous cell carcinoma.
Vocal cord carcinoma. So this is a fungated, it's different from this. So this is a fungated greenish yellowish mass that involving the entire right vocal cord from the commissure, anterior commissure until the posterior aspect of the right vocal cord, involving also the anterior 1/3 of the left vocal cord. So this is usually a vocal cord mass. What we have to do, we have to do biopsy, and then after the biopsy, we have to decide the staging. If it's a cancer, usually when we see cancer, you have to say we have to stage the patient. So it depends on the biopsy. If the biopsy is cancer, malignant cells, whatever we have, a squamous cell carcinoma, the most common, so we have to do staging. So what is the staging system? Anybody knows about anything? So this is a
TNM.
step. Excellent. So we have to stage the T, the tumor, the lymph node in the neck, and the M for metastasis. You have to check which stage is this, stage 1, stage 2, stage 3. It depends on the T, N, and M. And then you have to say what is the proper treatment. So we're not going details, but just I want to be familiar with this. Usually patients come with hoarseness or shortness of breath. You did the flexible fiber optic, you find this. And usually there is a risk factor, whatever the patient is alcoholic or he's smoking. He's a smoker since a long time. So this is a pediatric patient, is come with stridor. You did the scope, you find this. So what is this, guys?
Stenosis. Subglottic.
Okay, so what do you think, Faisal? Salman, Badr, Nasab.
Stenosis دكتور.
Okay, so it's called stenosis, but we don't say only stenosis, guys. So stenosis, laryngeal inlet.
vocal
كل مكان ممكن يكون stenosis، فاهمين شباب؟ يعني ممكن يكون epiglottic stenosis، ممكن يكون epiglottic stenosis، ممكن يكون subglottic. You have to determine which side.
هذه سبجلوتيك يا دكتور صحيح؟
Subglottic.
So this is the vocal cord. So if you have any adhesion here, we say glottic between the right and left. But here
Below.
this is called subglottic. Okay. So what is the treatment of subglottic stenosis?
سيرجري غالبا دكتور.
Surgical. So surgical option. We have different surgery. We do balloon dilatation. We just insert the balloon here, and we do dilatation of the bone. So all of these licensed. and it cut, or if it's very long, so you have to do CT. If it's very long segment, we have to do cranial resection. But this is very advanced, so just say surgery, okay? So what is this? So we'll go from this video first. So this patient, he come to the emergency room, gasping of air, sitting upward, forward, and you see the patient, you did the lateral neck X-ray, and you find this sign.
Epiglottitis, دكتور هذا.
Thumb sign.
Thumb sign, epiglottitis. So what is the organism that's causing epiglottitis?
H influenza.
Parainfluenza virus.
Okay. So with the scope, well, we don't educate the patient to do any maneuver in the airway, but if you do the scope, you will find this. This is the thumb sign and the omega shape of the epiglottis become like this, inflamed and swollen and red. So it's very difficult sometimes to intubate the patient, but this is how we see it from inside. Okay, this is a patient, pediatric patient, 3 years old, coming with a snoring and anterior rhinorrhea for a long time, more than 3 months. He's a mouth breather. You examine the patient, you find what is in the examination. Usually we find, for example, you found dark circles under the eyes. The patient opened the mouth, and you suspecting one of the common disease, and you did the lateral. You want to do scope, but the patient he refused because the scope is better in this case. But the patient is refused, so you did the lateral neck X-ray, and you found this lesion. So what do you think, guys, from this scenario, brief scenario?
Adenoid.
Adenoid what? Give me the...
Adenoid hypertrophy.
Adenoid hypertrophy. Don't say adenoiditis, acute adenoiditis. All of this is not, because I give you a chronic mouth breather, is a chronic disease. So where is the adenoid exactly? I will tell you now. So you see the mouse now is moving?
Yes.
Okay. Usually the black is the air, like here in the room, outside, like in the oral cavity. So here the nasal cavity is okay. Going posterior, see the air column here. It's become more narrow. It's supposed to be like this. All of this black. Okay. So now here we have a narrow air column, become more narrower here, and then start to open at the oropharynx. So all of this is adenoid. So this is skull base. This is the base of the nasopharynx. So all of this is adenoid. But it's better. So this is an X-ray, but it's better and more sensitive and the gold standard to do flexible fiber optic through the nose. We do flexible fiber optic through the nose. We pass the nasal cavity and we see the nasopharynx, and you found the adenoid. And usually you have to say the adenoid is very big or small. Is it obstructing the trachea tube? Is it obstructing the posterior choana? Totally small size. So you have a very rich information rather than the X-ray. But if the patient is refused, you can do X-ray with the symptoms and signs. You can say this is adenoid hypertrophy. So what is this, guys? It's what the adenoid is. يا شباب عبد الرحمن خلاص ما شاء الله. طيب نشوف مصعب الدوسري.
Yes, دكتور.
Do you know what is this as a spot diagnosis, or I'll give you scenario?
لا والله ما أعرف.
طيب محمد الغبالي.
ما أدري والله دكتور.
ما يعرف يقول ما يعرف. It's not a big deal. It's only we are see how many information we have only. Okay, عبد الرحمن.
Inflammation of the sinuses.
So this is axial cut, okay, guys. It's not coronal or sagittal. Axial cut at the level of the posterior aspect of the nasal cavity with the nasopharynx. The patient he come after delivery in the delivery room. become agitated and oxygen saturation it's going down, desatting. But when he's crying, it starts to raise the oxygen saturation to the normal. So usually this is called choanal atresia. So this is the choanal atresia here, guys. So we have the bone is growing and is not opening due to the defect in the opening of or canalization of the posterior aspect of the nasal cavity of the nasopharynx. So this is a bone supposed to be not here. هذه شرحناها لكم يا شباب. مين كان معايا في البرزنتيشن حق الراينولوجي؟ شرحنا هذه الحالة في الراينولوجي بار choanal atresia.
أخذناها هذه بمحاضرات دكتور ولا وين؟
إيه خدناها في المحاضرات.
ما أتذكرها والله.
Okay, so this is called choanal atresia. It is a field of canalization of the bone of the posterior choana of the nasal cavity with the nasopharynx. So here we have complete obstruction of the airway bilaterally. This is emergency. If it's unilateral, sometimes the patient come late and live. So just write choanal atresia and review my presentation before in rhinology. We spoke about this and what is the pathophysiology of the choanal atresia.
Okay.
Okay, I think this is obvious for you. So the patient, he come with stridor and gasping of air after he was playing with round objects. So the mother brought him to the ER, cyanotic. We did X-ray and we found this. So what do you think, guys?
Foreign body aspiration.
Foreign body aspiration. So is it enough to do only anterior, AB, X-ray?
No, we should take a lateral.
Why we do lateral X-ray?
To know if it's in the esophagus or trachea.
Excellent. So what is this instrument, guys?
هذا الريجيد
rigid laryngoscope or bronchoscope.
Okay, so this is the bronchoscope. If I want to remove that coin or that foreign body, I have to use instrument, whatever, stethoscope or bronchoscope. So now it's different from sinuscope and flexible fiber optic. So these two instruments is different. So we have bronchoscope. This is the bronchoscope. If you have ventilation holes here, so that's mean we have a bronchoscope. The stethoscope, there is no ventilation holes. Why these ventilation holes? Because sometimes if you have a foreign body here and you go to the bronchus and the larynx, and the foreign body is closing here, so how to aerate the patient is by this lateral holes of the ventilation. But in the esophagus-scope, we don't need any ventilation. This is how to know the esophagus-scope from bronchoscope. So what do you think this foreign body, is it an esophagus-scope or is it an esophagus or bronchus?
It's an esophagus.
Why?
Because there is no tracheal rings.
Excellent. So there is no tracheal rings or the U-shaped tracheal rings. So this is an esophagus most likely. Okay, guys, we have the last section is the head and neck. You have to review. So this is a case of old patient. He come to you with this left neck swelling, and he is complaining as well for nasal obstruction since long time. He's a smoker. So what do you think, guys? What is this neck swelling in this old age? So we have a differential diagnosis, right?
Yes, هذه غالبا nasal carcinoma تكون في level 5 lymph nodes involved.
Okay, so excellent. So this is the usually if we have any upper airway cancer, it will drain to the lateral neck lymph node. Okay, so when we have a patient, old patient, he has a nasal obstruction and then he has a neck swelling laterally. So that's mean there is something that drained to the lateral lymph node. And usually this is the malignancy. So you have to do scope in esophagus to see the origin of this. And then you have to examine the lymph node, all the lymph node in the neck. So this is a nasopharyngeal carcinoma with neck lymphadenopathy. So what is the treatment of nasopharyngeal carcinoma?
Surgery combined على حسب عادة TNF.
Okay.
find either of chemo or radiation على
Okay,
حسب.
usually in nasopharynx we do chemo radio. Okay, we don't do surgery in the nasopharynx because this is it is a functional affecting the nasopharynx. We couldn't remove the nasopharynx, so we have to do chemo radio in any nasopharyngeal cancer. So what do you think? I will take biopsy from where? From this lesion or from nasopharynx?
From the nasopharynx.
Excellent. So don't touch the lymph node. Try to find the primary of the malignancy and the disease. So the primary here is a nasopharyngeal malignancy. It's next to the lymph node. Okay, so what do you think this, guys? What is the differential diagnosis of the central neck mass in pediatric population?
هذه يا اما تكون تايروجلوسال داكت سيست ولا ديرمويد سيست ولا تيراتوما ولا تايمس سيست.
Okay, so when he's moving the tongue, he's going up. So what do you think?
Thyroglossal cyst.
Thyroglossal duct cyst.
Thyroglossal duct cyst.
So what's the treatment of thyroglossal duct cyst?
Cyst trunk operation أو observation لأنه 1% of transformation to cancer.
Yes, but observation, we usually don't say observation unless if there is infection, so we have to observe until subsided because the patient, he has a recurrent infection. You get that, Rahman? So if you leave it, he has a recurrent infection, sometimes it causing fistula, sometimes it causing redness in the skin, and discoloration of the skin from the recurrent infection. Because any upper tract infection, the patient will come with infection and pain in this thyroglossal duct cyst. So the treatment is cyst trunk procedure. So what do you think is this?
هذه اللمف
Mikulicz syndrome.
Okay, so here there is a swelling, right, in the angle of the mandible, asymmetry with facial nerve paralysis. So what do you think?
Parotid.
Excellent. So parotid. So what do you think? Is it benign or malignant? We have facial paralysis. Okay. So what is the most common benign parotid malignancy? Parotid tumor.
ما أخذت والله صراحة هذيك السؤال.
ما أخذت الباروتيد سيريبرال جلاند tumor.
لا ما أنا ناسينها.
Okay, so you have to know differential diagnosis. So I said there is a parotid mass. You have to know the benign and the malignant. You have to know the most common benign. So the most common benign is a polymorphic adenoma. The most common malignant is mucoepidermoid carcinoma. Okay, so you have to know all the differential diagnosis and all the causes of the malignant and benign. These are very important, guys. So what is this?
tracheostomy. لا
الا tracheostomy.
Tracheostomy.
Okay, Salman, tracheostomy or
ايه tracheostomy.
excellent. So what is the indication of tracheostomy? Why are you using tracheostomy?
كان في airway obstruction.
طيب, where is the
Trauma.
respiratory failure.
Excellent.
Facial trauma.
Vocal cord paralysis.
Excellent. Vocal cord paralysis. We have upper airway obstruction, okay, at the level of glottic and above. Whatever you have trauma, you have glottic lesion, you have stenosis. So all of these upper airway obstruction, you can do tracheostomy. Overweight, we have intubated patient for a long time. We have to move from the intubation in the tracheal tube to tracheostomy. Okay. So this is the last of my tutorial discussion. I tried to cover most of the subject. So this is the most important things that you have to know and you have to be familiar how the things is running. Because sometimes when you come to the final exam,